Hi, and welcome again to the series of lectures that I've given to the UBC grad students. And today's topic is going to be managing posterior upper back implants, particularly where we're having to look at sinus procedures. There's two different ways. I'm going to go into those right now. So with that, I'm going to go on to the presentation here. Good. So we should be looking at the full screen now, and I'm going to be up in the top right corner. And let's talk about maxillary posterior dental implant procedures. So first of all, who am I? I'm Dr. David French. You might have seen some of my other videos already. I was a general dentist, graduated 1991 at U of A, and then specialized in graduate periodontics in Vancouver, UBC. I still teach there today at UBC. And I'm a periodontist full-time. 90% of my practice is dental implants. I've founded in numerous different academies. I've published a number of papers in the literature, past president of the academy here in Alberta, and a few other things. So with that, let's talk about the two different approaches. So there's two ways of getting the bone elevated back when the bone is missing. One is to open the sideways access of the sinus. So you're coming in the side, and that's called the lateral window access. Technically, it's a Caldwell loop procedure. It allows us visually direct elevation of the membrane, and it requires some form of bone graft placement. The other way is a crestal approach, where you're coming from where the teeth were and just pushing up, and that's called osteotome-mediated sinus floor elevation, or OSFE for short. And it's an indirect approach, and it doesn't always require graft replacement, which we'll talk about in further series here. So why do we even talk about sinuses when we're talking about upper back implants? And that's because 50% of the time we're going to be deficient in bone. You can see here this outline, that is the shadow of the sinus. This is the residual bone height. We call that RBH. And oftentimes it's around that number. We'll look at the actual stats here in a few minutes. And why does that happen? Well, the sinus is basically a bag of fluid, and it tends to droop down. And you can see here, there's the roots and cross section. You can see it actually drooping down in between the roots. So when you take this tooth out, you end up with almost no residual bone. So what is the average? At this tooth numbers 4, 5, 6, 7, that's the bicuspids, first molar, second molar. So really we're talking about first, second molar, where the average height is about 5 millimeters. And we call that residual bone height. And then the width is usually never an issue because the ridge doesn't go to that knife edge. So we typically have 6 or 7 millimeters in width, and that's all we need for a standard molar dimension implant. So in the maxillary posterior, we're not adding bone width, we're trying to add bone height under the sinus. So if we are going to do that, we have to know some numbers. If we look at the sinus here, this is the area of the nose, this is the cheek area. There's a wall of bone, and that tends to be about 2 millimeters thick. But it can be quite a bit thicker in some circumstances, and that makes doing the procedure more difficult. Also, there's a thickness of mucosa, which means there's a soft tissue lining. It's almost a skin. It's called the Schneiderian membrane. And usually it's 1 or 2 millimeters, like you can see on the edge here. There's a little bit of the sign of the membrane, but you see this elevation of it here, and there's an infection at the end of that root, and that's why that sinus is elevated. So if we see a thick membrane, we want to be looking at possible infection. Or in a case like this, if we don't see any membrane at all, we know that it's into that very thin area. If you see 1.8 millimeters plus minus 1.6, that means that membrane can be 0.2 millimeters thick. And that's like very, very, very thin membrane. You could imagine trying to peel the membrane off of an egg. If it was less than 0.2 millimeters, it would be very difficult. And the other thing that the sinuses have is they have this cross-sectional septa. So it's like little ridges within the sinus, and that can make doing the elevation very difficult. So how do we find all this out? We have to use cone beam tomography, and that is the gold standard. You should not even consider doing a sinus lift procedure using a lateral window in the absence of proper imaging based on this recent cross-sectional series. So why is that? If I take a look at this, I can see the outline of the sinus floor. This looks like a pretty easy lift. It's isolated, but in 3 dimensions, we see we're actually missing the sinus floor completely. So I have nothing to hold in my graft. I effectively have a fully open system. If I had attempted this without knowing that in advance, we would have gotten ourselves in trouble. And also you can find, as we did on this side, additional pathology. So what is the shape of the sinus? Well, it's basically an upside down pyramid. This is where we have the cheek side. This is the nasal side. And there is a drainage point right here called the osteotome. And that is basically about 25 to 30 millimeters up there. Now, this is lined with a special kind of epithelium that has movement, and it moves fluid. And why is that? It's because the sinus is going to produce about 2 liters of fluid a day. And if you don't have a way of moving that out of there, you're going to have some serious sinus congestion. And that osteotome, which basically drains the sinus, is 30 millimeters above. So when we're doing a sinus lift here, we never ever want to get too high because we don't want to block off that sinus area. And if you have a very thick membrane and you're adding a graft underneath it, it might not even take a 20 millimeter lift to block that out. And that's why you have to look at this on a tomograph before. So again, we mentioned about the sinus septa. There's about 32% of the time a septa will be right in around the first molar. And that makes it very difficult to lift. You could imagine if you're trying to take an old carpet from a floor, if you have a stairway, around the angle is where you're going to get the tear. And if we're lifting over here, oftentimes we end up having to do 2 miniature lifts. We lift the front half of the site and the back half in 2 separate lifts. So when did this all start? Back in the 1980s, there was the very first description of using this Caldwell-Luke approach, which is the lateral window approach. And then it was using iliac crest. So they take a part of the hip bone, break it up into small pieces, and then do the graft and then subsequently the implant. The problem with that was the bone itself was prone to remodeling, and you would lose about half of your height. So you'd have to gain 20 to get 10. As well, there was donor pain and complications, and not many people line up to have their hip done just because they need a tooth in the back. So this is, groundbreaking procedure, but not what we're doing today. So in 1987, then, there were some early studies that looked at using basically bone in a bottle. So this is xenograft, which is cow bone that's been cooked to a point where it's a pure ceramic. And we call that porous hydroxyapatite. And why do we use that? It's because the shape of the bone is very similar to the shape of natural bone. So the bone cells can move in and resorb and remodel this. So this was the first case report where that was done just using particulate. And then there was a series of studies that were done to show that this might work clinically and also whether there's any histology to show the bone. So the first of that was Wheeler's and in 1996. So they looked at using hydroxyapatite alone or mixing it with iliac crest or mixing it with oral bone where we can get from behind wisdom teeth or down in the chin. And then they did some biopsies all the way out to 3 years to take a look at the outcome. And what they found was about 11 to 20% of vital bone in the area. Now, that's not a bad amount. It sounds like it should be higher, but even in native bone, you always have marrow space and empty areas. So 20% vital bone would be a very good target number. Interestingly enough, this study found the oral autogenous didn't have significant benefit. What they did conclude, not really related to this since it was more of a technique paper, was that if you have less than 3 millimeters of residual bone height, then you want to use autogenous bone. If it's more than 3, you might be able to use HA as a substitute. And if you have more than 5, you might even do the implant at the same time. And this was really more based on his descriptive, though. There isn't really strong data for these positions. So is it a good study? Yes, it's a good study because it was a landmark study showing that this procedure works, but there's many things that are lacking in it. There was no definition of success criteria. They used a mix of implants designs, a mix of bone percentages, and so it's more of a how do I do this paper. One of the landmark papers that followed was done by Froome and his group. Stephen Wallace in particular has done a lot of work in this area, and it was part of the New York University's implant program, and they had clinical and histological data on a large sample. And what they did uniquely in this study was they looked at the different factors that made success. So what type of implant, what type of graft material, whether a barrier was used, and what the effective healing time was. So it was a whole series of studies. So very well done. Vital bone percentage at 6 to 9 months. So that means we do the graft and we go in there and we figure out what it looks like after. So what they decided to do was standardize the amount of autogenous bone, and they used an oral autogenous bone, so intraoral harvesting. You can do that. For example, there's this device here that has a blade, and you scrape that backwards over the bone and it collects it inside. That's called a safe scraper. We use that, and there's an Ebner file that's very similar. The nice thing about this is it only requires 1/5 of the bone to be autogenous. So we don't have to go to the chin anymore like we did in the early days. We were getting 50-50 ratios. We now realize that based on the work of Froome and his group, that we don't need 50-50 ratios. We can have a 1/5 ratio of autogenous bone. They looked at also the addition of that bovine HA with autogenous, as well as something called DFDBA, which is allograft. And sometimes people know that as cadaver bone. And that's what this is here. So it's basically cadavers where the bone has been decalcified, freeze-dried, and basically chopped up into tiny bits. Now, why do we use that? Is that in theory, some of the bone proteins that stimulate bone growth are within that product, and so it may stimulate bone growth. But you can see here, it didn't have a really significant difference, only 1%. But what if we do that without autogenous? Does this have enough power to generate bone? And you can see a significant reduction in percentage of vital bone. Or if we just try HA alone, so just using the one type of bone, the one that we can buy in a bottle, the xenograft or cow bone, and it's lower, but also very highly variable. They had outcomes where there was almost no bone formation. So the standard that they've developed from this is that you should be using HA with about an 80-20 mix, or possibly adding this in as well. But what they also found, and this was interesting because they did a series of histological examinations, is that the bone quality increased over time. So let's say that you did not have access to oral autogenous and you wanted to use HA alone. You might just then add your time, say give it another 1.5 years, and then you can go back in and you would have higher bone formation. But otherwise, anytime you can add autogenous bone, it does improve your outcomes. So then there's also the effect of a barrier. So when you open the membrane to lift the sinus up, then you put the bone in, you want to put something back over top of it. And the reason for that is the skin of the cheek area can grow into the bone and it can reduce the quality. And that's exactly what they found, is that with the membrane, they get that kind of 29%. And again, that's about what they have with their previous study. So we're looking at very reliable, good quality bone, but without a membrane, we had a significant reduction. So a membrane should always be used. So we know that, and that's been part of a sinus consensus, which was a national meeting on doing sinus procedures. And the purpose of that is to keep the graft from migrating, to block the connective tissue. That's really the primary reason. And because of that, we have better bone quality. But you should use a long-term resorbable collagen membrane. Don't use the EPTFE like this picture here. I'll show you a case later. In the early days, that was the membrane of choice. But the more we know, the more we do things properly. We use collagen membranes that have about a say a 2-month resorption time. That's long enough to block the epithelium from growing in, but it doesn't give you a risk factor of an exposure. So what about the graft material? As we saw already from Wheeler's group, that 80-20 mix of hydroxyapatite and autogenous is best. But the systematic review, so these are articles, Petrusin, for example, looked at all the papers published on this, and there's really not a graft material of choice. So you can't say standard of care. What you can say is, if you were doing this, the science probably leans this direction, but there are other choices that you might use if that is your preference. There's also in research platelet-derived growth factors, where we take blood, we spin that down, and we concentrate some of the growth factors that are built within the platelets. Certainly that's very promising, as well as synthetic factors like bone morphogenic protein. So these are all things that are kind of in research, experimental, but the reality is none of these have added at this point a proven superiority. So at this time, it's HA in an 80-20 mix with autogenous, and give it 4 to 6 months or a bit longer, and you'll have bone that you need. One thing we do know, and what we don't use anymore, is machined implants, especially in grafted bone, because the roughened surface implants also have better survival. So what is the process like? Well, it takes about an hour. You need post-op antibiotics, absolutely. So if you have someone who's declining to use antibiotics, do not use this procedure. Post-operative pain is about 3 to 5 days where you're going to need some pain medication. You will see quite a bit of swelling in the first 3 days, and it resolves usually by about 10, but you can have significant bruising, and especially on the inside of the bony wall, there are some small vessels that transfit right within the bone. And when you cut through there, you might nick those, and you can get a bit of bleeding that goes on under the wound. And so then you get quite a bit of bruising in those cases. Longer term, well, it takes about 4 months for the bone to heal. As we saw from Wheeler's work, it's at least that long to get your vital bone percentage. And then you put your implant in and you wait another 3 or 4 months. So you're looking at about 7 or 8 months before you get your teeth. And again, as we've mentioned, if you have poor bone quality, you can always just wait before you put that implant in, because you get more bone quality with time. But also long term, especially if a patient is prone to sinus problems, then you can get these long-term persistent issues. And I say issues because they may not be frank infections. They just will say that they're feeling different, or they might have a headache that seems to come and go. So again, I think you have to inform your patients of these outside events that may happen. It certainly isn't common, but it definitely is possible. So again, if you have a base bone, remember we saw the residual bone height of about 4 or 5 millimeters, you could consider placing the graft and the implant at the same time, because you have enough anchorage to get the bone in place. So that'll save you the healing time. But if you have less than 4, they recommend doing a staged. But the reality is, well, actually also the less autogenous, as we mentioned before, the more you want to extend this time. But most importantly is, this is an old recommendation, because right now, if you have 5 millimeters of residual bone height, frankly, we don't do a lateral sinus lift. That would be something that would be unnecessary. So we'll go into that later when we look at the osteotome approach. So again, what does it feel like? It's the equivalent of about having 2 teeth extracted. So 2 molar extractions, and most patients that are missing teeth can relate to that. If we get the donor for the autogenous bone from behind the wisdom teeth using those back action scrapers, it's really not that uncomfortable, maybe equivalent to a molar extraction there. If we do, as we did in the old days, need a lot of autogenous bone and we go to the chin, that creates significant bruising, swelling, and paresthesia. So it's a site that we don't really use anymore. Most of the time we can manage with some typical ibuprofens or ketorolac or something like that. Maybe some low-grade narcotics like Tylenol 3 and Tramacet. What about the infection risk? Well, the general estimate from most studies is about 2.5%. But the thing about infections is they can be prolonged. They can last up to 4 weeks to get cleared, and you might have to do a secondary procedure to remove the particle graft if it does get infected. Again, these infections are much more common if you have a history of sinus infection, if you're a heavy smoker, or if we don't have access to penicillin as our standard routine coverage. And why is that? That's because that is the treatment of choice for sinus infections, and we're preventing them. Alternates do not work as well. So clarithromycin, for one thing, has numerous drug interactions, but also isn't as effective. And levaquin, also not as effective, but does also have a tendinitis or a tendon damage risk. So these are things that might be explained to your patient. In my personal opinion, I don't do lateral window procedures in the absence of a penicillin class choice. We might get antibiotic testing done so that we know. Most patients that report an allergy, in fact, are not, but we do get testing to find out. So again, if we're looking at doing a sinus lift procedure, what are the go, no-goes? Well, if a patient has a medical psychosis, you do not do this. If they are poorly controlled diabetics, you do not do this, or if they've had radiation in the area. So those are the reasons for not even going ahead or considering. But what about our risk is being increased? So when do we look at this and say we need to give the patient more informed consent, or maybe have this handed off to someone who has higher skill sets? For example, there may be a general dentist who's doing some lateral sinus lifts, and you would certainly, if they had all of these complicated factors lined up, you would certainly not want to do that. So again, history of previous sinus infection problems, heavy smokers, non-compliant patients. So these are the ones that don't show up for post-ops or don't take the antibiotics as prescribed. And of course, penicillin allergy, we've highlighted that. And the reason for that is we actually published a paper back in 2016 that looked at our complication rates with implants. And in general, we had a 13 times, well, first of all, we have 3 times failure rate of the implant, but more important is this 13 times infection rate. So if you have a 2.5% risk and you multiply that by 13, that's a pretty high number. So again, that's why I don't do sinus lift procedures on patients with penicillin allergy. This is not hard science. This is not an absolute contraindication, but it's my own personal draw the line in the sand. And again, so again, if we take a look at that, even without grafting, our infection rate was still high. So let's take a look at what some of the complications are in the literature. So there's this one study here that looked at 70 patients where they did 81 lateral windows over a 5-year period. And what they found was they had a self-reported tear rate of 44%. So that means when we're lifting that membrane, imagine you've got an egg and you're lifting the membrane off the inside of an egg, you have a tear rate of 44%. Now this is higher than most other reports, but still that's something to keep in consideration. And they had about a 10% complication rate where they either had cyst or infection. So again, this is higher than some other reports. But what was interesting was that if you did have a tear, you had a higher association with complications. So again, if you do get a membrane tear, that might be another point where you choose to not carry on with the procedure, close up and stop. And what is that threshold is typically if the tear is small, about 3 or 4 millimeters, the membrane itself is being elastic. As you lift it, it kind of moves itself together like a balloon shrinking. The tears are actually self-sealing, but if you have a larger tear, you have to repair that with a membrane put up inside the sinus, and those are probably where you're getting more of your complication from. Curiously enough, even though these were associated with these cyst and infection complications, it didn't actually affect the implant survival. And I'll show you my own case later on here where we had implants that survived, but we did have quite a complication with infection. So the other thing to consider when you're looking at that risk of complication is whether there's a pre-existing condition of sinus problems. And what this study showed is that if they do get a tear, if the healthy sinus was present before, it doesn't tend to be a problem. Now, this is not high numbers. You're only looking at a 2 out of 5. So, it tells us that if you have somebody with a pre-existing condition and you get a tear, that's likely going to be a problem case for you. So what do we do to reduce tears? Well, we used to use a drill as we're cutting through the bone. So when we're cutting that bone wall, 1.5 millimeters in, we have a membrane, but it's very difficult to not nick the membrane, and that early nick makes a tear. So now we have these devices called piezo's. They're ultrasonics, and what they do is they have a diamond that works at a very high speed, and what it does is it can cut bone, but it won't cut soft tissue. So we can literally go right up to the membrane, push against it, and not get a tear. This has made a huge difference in rate of tear. So when we look at the early reports, as we saw before here, 44%, numbers are much more lower than that because of this new technologies. So here's an example of us having cut open the window, and you can see the membrane sitting underneath, and we could get right up against it without creating any risk of a tear. In this case, we're using the back action scraper to collect the bone, and we're mixing it with that xenograft in that kind of 80-20 and placing it in the sinus and closing over. So we can see the before and then the after, where we have had, let me just go back. This is a big old empty space in the sinus here, 1.5 millimeter wall. And that's now our window was prepped here, and the bone is grafted all the way over to the other side. So again, it's a very successful technique. We can put implants prior to places where you could not. This was a 1 millimeter, 2 millimeter floor. There's no way that you can place an implant there without doing this procedure. So it really is a game changer for upper posterior teeth in cases of very low bone. And there we are with the implants. But even using a piezo, as I said before, sometimes that membrane is so thin, you can literally see through it here. It's so very thin that even just touching it or trying to push it and manipulate it, it's like a bad nylon that just runs. And in this particular case, these two tears ended up joining right across. So we had to abort the procedure because now it's much more than 3 millimeters. We placed a membrane to just seal the area off to protect it from epithelial migration and closed the procedure. And then we changed our tack and we went to using that little bit of existing bone beside the teeth. Instead of lifting the sinus, we used what we had to work with. And that goes back to using the osteotome approach, which we're going to be explaining later on here. And that gives us now a 4-year follow-up. And you can see just using the existing bone, we had a good outcome. So there's other devices out there other than the piezo that can help reduce risk. This is a spinning diamond basically, and it can also go in there and create a window. I don't necessarily use this. One of the things I don't like about it is it's basically dimensionally very small. It's predetermined by the size of this, or you have to do basically Audi rings to try and make it all join together. I find the piezo is more flexible, but it is another device out there, and I have many colleagues that swear by this technique. So let's take a look at this case and say, do you want to try doing a lateral window here? Do you see this step in the bone? So the old root was here, the sinus dropped down in between the two roots, but there's this residual ledge. So we have to first cut into the window very high. This is at least 10 or 15 millimeters up, and that's very hard to get access that high. Then we have to somehow remove the membrane over that step without creating a tear. So that's not a very good case for doing a lateral window. And again, that's why imaging is important. Just because this is on average 1.5 millimeters, you can see here it's much more here. So again, that imaging is important. In this particular case, we did a 2-stage osteotome. So we pushed the sinus up to this position using an indirect and then a secondary indirect to get the rest of the height. So let me show you what an infection and exposure looks like. So this was one of those cases where everything was bad from the beginning. This was an early case that we have done probably more than 20 years ago now. So reported penicillin allergy, that was before we had data on that risk factor. Patient who is a smoker and also poor compliance to follow-up, you'll see later on. So we did 3 implants at the same time as a bone graft. So we had at least 5 or 6 millimeters of bone to anchor those. And at that time, we were using a 1:3 ratio or even a 50-50 ratio. And also then we were using a goretex membrane because then it was the state of art. So everything went well as far as the procedure. We had a 1-week result that was good. And then at 3 weeks, he failed to show. He was working on the rigs out of town, never came back. He presented then 8 weeks later with an active infection because the membrane got exposed. So what happened is here we are here doing the lift. We had excellent intraoral source because there was a tori there. So we had lots of intraoral bone. We mixed that with the HA. And you can see the 3 implants were placed simultaneous because there was good anchorage. We used a goretex membrane, and that's what we would not do today because this little tag poked out through the gum, and when it did, it got infected. And you can see at the 1 week it was fine, but the 3 week we didn't see. But you can see the membrane just underneath here, and you can see how thin that gum is, how that might poke through. And in fact, that's what happened. You can see that it's yellow here, and that means it's infected. And that was an access for bacteria into the sinus and the graft material. So we had suppuration, which is what this messy stuff looks like here. And we eventually got that to clear, but it was 3 or 4 weeks of using an IV antibiotic organized through the hospital. So this is not something that's easy to deal with. And so, again, I would recommend anybody doing a lateral window procedure, look at your risk factors and look at your skill sets. But as I said with the previous study showing, even though there's complications, the implant survival rate was good. And so we were able to successfully finish the case. So again, what about lateral sinus lifts do we like or not like? Well, one thing is they're time consuming. They add at least an hour of chair time because it's a separate procedure, and they add at least 4 to 6 months of healing time for that bone to mature. It is a higher risk procedure in dentistry than almost any other procedure short of maybe ridge augmentation, bone grafting procedures. So there's a risk of tear between 20 and 40%. There's risk of graft being dislodged, especially if that tear is unrecognized. And that infection rate, as you saw, ranges, but let's say that's 2.5% is probably your best case scenario, up to 10% or more, especially if you have cofactors like previous histories of infections. It also adds cost, a minimum $300 or $400 worth of material cost as well. And yet, in 1998, which of course this is an old consensus, there was a consensus that said implants should be done with a lateral window procedure if the bone is less than 8 millimeters. Now, that was when we had machined implants and they had low survival rates in non-grafted sites. So this really is historic, but it does state that, you know, once upon a time, we were causing a lot of unnecessary pain and trauma and increasing risk of infection. And so we've moved on from that. What's helped us with that is, again, we don't have the tear, we don't have the donor site. What's helped us is the type of implant is rougher and it can grip the bone much better. Even low density bone now is a viable posterior site. So this is the case that changed my practice. In year 2000, we had here about 6 millimeters of bone as a residual bone height, and that would conventionally be a lateral window procedure. But there was a technique that had been talked about over the last 4 or 5 years at that point called the osteotome approach. And so this was our first case. You can see the elevation right there. And that's what the bone looked like when it matured. And you can see that all of that gain happened. And I can tell you we didn't graft bone with that. We simply did it at the same time as the implant. We're going to go and show you how we do that now. But that changed everything because I was doing about 25 sinus lateral procedures, again, the high risk procedures. And now I might do 7 or 8 a year, only when the ridge is very deficient. So I got hooked in 2000. And in fact, that's also when I got hooked on windsurfing. And this was me down in the Mayan at one point.